And you also have an enzyme circulating in your body called oxytocinase, which binds to oxytocin and keeps it from getting to the uterus, from getting to the receptors. And during pregnancy, you have a higher level of oxytocinase, of the enzyme, than oxytocin. So whenever oxytocin goes into circulation, it gets bound by the enzyme, it gets blocked, and it doesn't get to the uterus. And as you get closer and closer to term, the amount of enzyme stays the same, but the amount of oxytocin increases. And finally, you have more oxytocin, and it's not blocked, it gets to the uterus, and you contract. When we make you go into labor, we bombard you with oxytocin. We put it in the intravenous. So we have a huge amount of oxytocin as compared to what your body is producing, and we just override the block, and it makes you go into labor. Okay? So that's how we induce you. Do we need to? Not always. Do we do a lot of them in this hospital? Truth? Yes, we do. We do a couple of inductions every day. Most of them are just casual. Truly, most of them are just casual, and then we have the indicated and emergency inductions. So we make you go into labor. Well, what happens here if you go into labor and it's early? Well, if you go into labor at 37 weeks, okay, I don't think there are going to be any issues. We get down to 36, 35 weeks, probably not, but we've got a smaller baby, and there may be issues with a smaller baby. Once we get down to about 34 weeks, I'm concerned, and one of the things I'm going to do if you go into labor with a 34-week baby is I'm going to let the pediatrician know. And in fact, I'm probably going to call a pediatrician if it's even 36 weeks and say, listen, I've got a 34-weeker coming in, or she's in already, she's in labor. I think there might or might not be some issues, but I might want you to be around at the time of delivery. All right? So we're going to let the pediatrician know. Gets down to about 33, 32 weeks. There are issues. This is going to be a small baby. Remember I said that at 28 weeks, your baby's going to weigh 2 pounds. At 32 weeks, it's going to be about 4 pounds. We're going to have a small baby. There may or may not be some issues. Once we get down to about 30 weeks or less than that, we have a problem. This hospital is a level 2 hospital. Level 1 hospital, basic obstetrical services, looks after patients after 36 weeks, may or may not have an obstetrician, maybe the deliveries are done by family doctors, may or may not have an anesthetist on call. Level 2 hospital, like this one, has pediatricians, has some intensive care specialists as well, has anesthetists that are on call, has obstetricians that are on call, and we look after patients in this hospital from about 30, 31 weeks. Okay? We have a baby that's 31 weeks. We're probably okay to deal with it. We'll call a pediatrician, and if the baby needs to be transferred subsequently, it'll be transferred. Level 3 hospitals, university teaching hospitals. Okay? Interns, residents, neonatologists, fellows, all kinds of specialists in neonatal intensive care units. That's where the money is, right? Nursing care, nursing specialists to look after these small babies because they're going to need care. So if you go into labor and it's before 31 weeks, we're going to transfer you. We're going to get on the phone and we're going to try and do a transfer. Now what we do is we call a number. It's called Prenatal, and it's my responsibility to phone. So I get on the phone and I will call the person who's at Prenatal. It's an operator. She'll take the information and she'll say to me, where's your patient? What's her name? What's the situation? And then she will call the hospital that's on call. Now we have 2 level 3 hospitals, right? Women's College, Mount Sinai. Those are the only level 3 hospitals that we have in Toronto right now. And they take turns being on call. This one's on call, that one's on call. So suppose Mount Sinai is on call. I will speak, the operator will now get me in touch with the fellow or the consultant that's on call at Mount Sinai. And most of the time we know each other. Sometimes we don't, depends on who I'm talking to. And I'll discuss the situation. And I'll tell them exactly what I've got. And they'll tell me whether I can transfer or not. Right? And I'll decide at this end whether it's safe to transfer. Because if you're still early in labor, and your cervix is relatively closed, we've got time to send you down. On the other hand, if you're 6, 7 centimeters dilated, you're not going anywhere. The last thing I want to do is transfer you and have you deliver in the ambulance on the way down or just as you're walking through the door, right? So there are timing issues. So I'll speak to the consultant who's there and we'll discuss the issue and see whether I can transfer you. And it's not a matter of transferring you for your bed, because there's always a bed for you. It's, is there a bed in the intensive care unit for the baby? Okay? Is there going to be an NICU bed? And sometimes there are, and sometimes there aren't. And he'll say, okay, send her down, or he'll say, I'm sorry, we have no beds. Okay, a problem. So the operator is on the phone and she'll say, all right, I'm going to call Women's College. They're not on call today, but we'll call over there. Same situation, discuss everything and see whether there's a bed at Women's College. And even though they're not on call, if there's a bed, we're going to send you to Women's. So you're going to get transferred. Here's the problem though. Sometimes there are no beds in Toronto. There are no beds at Women's. There are no beds at Mount Sinai. The next phone call that's made is made to McMaster. So it's made to Hamilton. So we'll talk to the Women's Health Center at McMaster University. It's an hour away. Realistically though, it's 2 hours, right? So if McMaster says to me, okay, transfer her, here's what happens. And I don't want, I'm telling you this because it happens. Okay, I'm not telling you this because it's rare. It's not rare at all. It happens. We phone McMaster. McMaster says, okay, we have a bed. I'll come in and I'll discuss the situation with you and I'll say, listen, it's safer for the baby. It's probably not going to make any difference to you, although you're not going to get me. You're going to get someone else. And when you go to a university teaching hospital, you have to accept the fact that it's a university teaching hospital. That means there are interns, there are medical students, there are residents. Okay, that's part and parcel of the package. It's how I trained. That's what you've got to accept. Okay, and there are consultants. It's not like you're going to get straight to the students. There are consultants as well, and this is a high-risk situation. So you're going to get great care. You don't have to worry about that. I'm not going to be there. So you're going to McMaster. That means we have to call an ambulance. The ambulance gets here. It's going to take 15, 20 minutes or so for an ambulance to get here. And then we're going to put you in the ambulance, and you're going to take an ambulance ride to Hamilton. The ambulance ride is going to take 40, 45 minutes, another 15, 20 minutes or so to get into the city and into the hospital and up to wherever you're going to go. An hour and a half to 2 hours. I need to know before I send anybody out that I've got this 2-hour window. Okay, what happens if there are no beds in Toronto and there's no bed in Hamilton? Now we've got an issue. The next phone call that's made is made to Kingston. Okay, to Queen's University in Kingston. And then the next phone call is on the other side to University Hospital at the University of Western Ontario in London. Okay, so we're looking at a 2-hour, 2.5-hour ride to go to those. A little bit risky. I need to know that it's safe for you to go. Okay? And again, same thing, we'll speak to the consultants, and from time to time, we have to send people. Have I sent people to these places? Yes, I have. If there are no beds there, and that's happened, where do you go? You go to Ottawa. Ottawa's 4.5 hours away. What happens if you're going to go to Ottawa? What happens is you're going to fly. The ambulance will come and pick you up. It will take you to the airport. You're going to get on a plane, and they're going to fly you to Ottawa. An ambulance will meet you at the other end and take you to the Ottawa General Hospital or wherever you're going to go. Has that happened? Once. To my knowledge, there have been very few situations in Ontario where all of the hospitals have been closed. All of them. There are no beds in Kingston. There are no beds in London. There are no beds in Ottawa. Where are you going to go? You're going to go to Niagara Falls, USA, or to Buffalo. Does that happen? Extremely rarely. We keep our Canadians in Canada, right? But the realistic situation is, could that theoretically happen? Yes. Does it happen practically? No. And most of the time, you're going to get a bed in Toronto or Hamilton. Once in a while, it's going to have to be somewhere else. Okay? So for those situations where we can't stop the labor, and we're going to talk about that in a second, and we need to transfer you, we're going to do a transfer. Now, we want to try and stop the labor if we can. Starting labor is easy. Stopping labor is really, really hard. And if your waters are broken, you can't stop it, and you probably shouldn't stop it. So it's really, really difficult, and the medication that we have really doesn't work very well. In the old days, they used to use alcohol to stop labor. Alcohol. Now, beer is 5%, wine is 12%, liquor, scotch, gin, whatever is 40% alcohol, 80 proof, right? And you go to a party and you have a drink. Okay, she'll nurse one drink for the whole evening. You'll have the first one finished in 5 minutes. And there's your second one, and then a third one. And by the time you've had a second drink, you're smiling a little bit. By the time you've had a third drink, you're smiling all the time. And by the time you've had a fourth drink, you're drunk and you're sitting on the couch somewhere. Alcohol is toxic. Makes you a little bit sick, makes you a little bit delirious, makes you drunk. We didn't use regular alcohol. We used 95% alcohol, 190 proof alcohol. And we gave it to you intravenously. How drunk were you? You were really drunk. And not only were you drunk, but you had a drunk baby. Terrible medicine. Terrible medicine. If it worked, great. You're throwing up. And it crosses over to the baby. The worst situation was we couldn't stop the labor. Not only did we have a drunk mother, we had a drunk baby. Terrible medicine. So we developed other medication that would act on the uterus to try and stop the contractions, but it had side effects. And the side effect was that it made your heart race. And sometimes you'd have a heart rate of 170, 180, 200. It had side effects. So we don't use that anymore. So we're really having a hard time now because we don't have an anti-oxytocin yet in Canada. Okay? A medication that blocks oxytocin, shuts it down, shuts off labor. It's just not available. So there's the problem. There's the problem. Now, we've made tremendous progress. Tremendous progress. When I finished my residency in 1977, they were starting to develop at that time neonatal intensive care units to look after these tiny babies. Because if a girl delivered a baby at 28 weeks, it had a very high chance of dying or being significantly damaged. Very high. Baby weighs 2 pounds or less. Feeding issues, temperature issues, all kinds of issues, and especially respiratory issues for these tiny babies. Today, 30 years later, we're excellent. And now, if you deliver a baby at 28 weeks, because we have great specialists and intensive care units and wonderful nursing for these babies, 95% of them go home well. Still a small percentage of these babies get sick. They get infected, they have respiratory issues, and some of them still die, but not at all like before. So we've made tremendous progress, and now we're getting down to saving even smaller babies. And a number of years ago, I went to a talk and to a conference, and one of the talks was how small is too small. And we were talking about saving babies now at 24 to 25 weeks, babies that weigh 600 grams. What we need to do is we need to stop the labor. If we can keep that baby in a little bit longer, every week at that point is crucial. So there are issues with respect to you going into labor. If somebody comes in 28 weeks and membranes rupture, and it can happen anytime, waters break. What do? Well, usually we keep our hands off. But you're going to go into labor. Once your membranes have ruptured, you're going to go into labor. Now, the closer you are to term, the sooner you're going to go into labor. So if you rupture your membranes at 40 weeks, I expect you're going to be into labor in the next couple of hours. Yes?
Why do membranes rupture?
Why does it happen? Sometimes it's related to vaginal infection. Sometimes it's related just to the weakness of the cervix. And once in a while, I'll have somebody come in at 16 weeks. Membranes have ruptured. There's no amniotic fluid. And often it's because she's got an incompetent cervix. The cervix is just weak. It may have been because she's had a number of abortions. May have been because she's had a D&C. The cervix has been instrumented. And that may be one mechanism for the weakness. On the other hand, sometimes there is nothing to it. There's no story. And the natural history, I have to follow up on this question, the natural history of this situation is a girl comes into labor, comes into the hospital, and says, I'm 20 weeks pregnant, and she's having some bleeding. And you examine her, and her cervix is almost fully dilated, and the membranes are bulging through the cervix like a light bulb. Not much you can do at that point. This pregnancy is lost. And what happens is her membranes will rupture. She's going to lose this baby. And the next time, it happens even earlier. It might happen 16, 17 weeks. Now, if you're smart enough, and she tells you the story, then you might consider putting in a stitch. And very often around, if I've got a girl who tells me that story, I went into labor spontaneously, my membranes ruptured at 20 weeks, I think I'd make the assumption that this is an incompetent cervix. It's just not strong enough. And what we do is we make sure that you've got a viable pregnancy. We do an ultrasound at around 10 weeks. If it shows that everything is okay, the pregnancy looks normal, we bring you into the operating room and we put a stitch in and close the cervix. We just tie it tightly and hope it works. And a lot of times it does. Once in a while, it doesn't. Membranes still rupture or she goes into labor. But a lot of the times, we can put in a stitch, tighten it up, close the cervix, and then bring you in at 38, 39 weeks, take out the stitch, and induce you and have you go into labor. Now, you'll have heard some stories about people being induced, making you go into labor. And some people will say, don't be induced. The labor will be harder. The labor will be longer. You'll end up with a cesarean section. True or not true? Sometimes it is. I think if you select people properly, if we select our patients properly, then we can minimize your risks. But if we pick somebody that we induce and they're not ready, and it's not being done for the right reasons, is it going to be a long labor? Yeah. Could you end up with a cesarean section? Sure you could. Now, it might be because of the induction, it might be for other reasons that you end up with a cesarean, because there are lots of reasons for it. But we try to select as carefully as possible, and if you pick patients at the right time who are ready to be induced, they're going to go into labor, and they're going to go quickly. And the likelihood of having a cesarean section is no more than it is for anyone else. Is there a difference between the labors? There is. The difference between induced labor and natural labor is that induced labor sometimes comes on like a hammer. Natural labor comes on slowly. You're having contractions every 20 minutes, every 15 minutes, every 10, every 8. They're getting closer and closer, and you have time to adjust to it. When you're induced, you're not in labor, and 30 minutes later you may be having contractions every couple of minutes. So that's the difference. But is the labor any different if you're being induced than if you go on your own? And the answer is probably not. Once you're in good labor, labor's labor, whether I'm driving it or Mother Nature is driving it. If we put a bag over that intravenous and hide it and have an obstetrician come in and look at the contractions or feel the uterus and say, is she in natural labor or is she being induced? And we don't tell, you can't tell. Okay? So labor is labor. Once we've got you into a good labor pattern, it really makes no difference. Are there some risks when you're being induced? Sure there are. And we try to minimize these all the time. Okay? So there are some issues. So let's talk a little bit more now about the labor itself, right? You've been admitted to hospital. We're not premature. We're not post-mature. Post-maturity has its own set of issues. Okay? If we let you go too long, there are some issues. The placenta, and I have a placenta for you to see shortly, starts to calcify. And once you get to term, that baby isn't likely to grow that much more, although sometimes it does. It gets bigger. Sometimes the placenta calcifies, and for some babies, they actually may lose a little bit of weight. The amount of amniotic fluid may decrease. The baby may poop inside the uterus. All kinds of issues happen, and the risks start to increase after about 41 weeks. So is there a higher cesarean section rate for 41 weekers than for 40? Probably. For 42 than 40? Virtually for sure. So there are little issues that come up all the time, and I'm going to discuss them. Whenever we make a decision, we make that decision. I'm not going to make it unless there's a specific reason why I'm saying, you know, we need to do this. We're always going to talk about it. Okay? This is your baby. It's not my baby, and I want to make sure that you're happy with whatever decisions we make. As long as they're safe decisions, that's the crucial issue. Fair? Okay. You're in labor. You're walking around. You're managing. Husband's helping you. He's walking with you. Or not. And at some point, the contractions are going to get to the point where they're really uncomfortable. Now, having said that, labor is different for everyone. And there are some girls who are Amazons. They are really, really tough. I can't see it on their face. They don't show any emotion. They don't even show me that they're having a contraction, and they're booming along. And that's amazing. And then there are other girls who walk into the labor room with a target painted on their back. Says, I'm not even going to take my clothes off, stick a needle in my back. I want a needle now. Most people are somewhere in between. Some girls ask me, can I get an epidural the moment I walk into the hospital? And the answer is, no, you can't. And others will say, I don't want anything for pain relief. I want to have the baby naturally. Okay, natural to me means no makeup. You come in with a plan, and for some people, the plan works out. And for others, it doesn't. I want you to be flexible. So here you are, you're in labor, and you're having contractions, and we've admitted you. You're in. Your waters may or may not be broken. I probably will break them if I can, and we'll talk about that next week, because there are issues with respect to that. And you're having contractions and they're getting stronger. And now they're every 2 to 3 minutes, and you're not walking anymore. Now you're in the labor room, and you're in bed. Your husband's there. He's there to support you. He is there to try and help you. He is not there to have the baby. I want you to understand this. Don't get mad at him. Don't yell at him. Don't bite him. Don't hit him. Okay? Labor room's a dangerous place. I've seen some girls who are out of control. They're out of control with pain. And I've seen husbands standing over their wives saying, you don't need anything for pain relief. You can do this. You're tough. She wants to kill him. Be reasonable, okay? Be reasonable about how you manage things and the decisions that you make. You may decide, you know, I want to have this baby as natural as possible. I don't want anything for pain relief. I don't want an intravenous. I don't want a needle. I don't want an episiotomy. Understand that things change as we go along, okay? And I want you to be flexible and understand that. And I'm going to cooperate with you as best I can. But if I think you're doing something crazy, I'm also going to tell you that too, okay? I need to protect you. I need to protect the baby, all right? I need you to make sure that you're doing things that are safe. So you're in labor, and the contractions are getting stronger. You're starting to make a little noise in the room. You're grunting. You're grinding your teeth. You're digging your nails into his hand, and you're saying, I need something. Well, next week I'm going to show you my fish. I have a little stuffed toy fish that one of my patients gave me. And what she did was she just had it hanging on an IV pole, and she focused on that fish. She turned all of her pain and all of her anger, she just focused it on that fish. And she was great. She hypnotized herself by looking at this fish. Now, if that works for you, that's great. You put a picture up on the wall and say, I'm going to focus on that picture, and transfer all of your discomfort to that picture. You think that works? For some people it does. For others, it doesn't work at all. So think about something for pain relief. And there are a number of choices. So choice number one, nothing. You get a bullet to bite on. Make as much noise as you like. The labor room is sometimes noisy. Girls say weird things in there.
What the guys?
Sometimes them too, especially if she hits you. We just close the door. You know, it's a little bit like, you know, what goes on in Mexico stays in Mexico. What goes on inside the labor room, we just close the doors, and whatever we say to each other stays inside that door. If you need something for pain relief, be reasonable, because here are your choices. Choice number one, nothing. Okay? I don't want anything. I'm going to manage. And you have immense reserves, an immense ability to tolerate this discomfort. Now, understand that, you know, in the world, most babies are born in where? Africa, China, India, South America, and they may or may not have medical care. They may not have any medical care at all. That means lots of noise, lots of grunting, lots of potential problems, and sometimes lots of catastrophes. But this is Canada. We want comfort, right? We want it to be safe, we want it to be comfortable, we want something for pain relief. So the most common things that people get are a narcotic. And we use morphine. We use great drugs in the hospital. All right? So you're going to get morphine, and we're not going to give you a little bit of pain relief. You don't want a little pain relief. You want lots of pain relief. We're going to give you an injection. Okay? You get to the point where you want something, and you're not sure about an epidural. You're not, maybe I want one, maybe I don't. I'm not going to twist your arm. Very rarely will I twist your arm. Have an injection. So they give you an injection of a narcotic. Now, the morphine makes you a little bit sleepy. Okay? Narcotics make you a little bit sleepy. They make you a little bit stupid. Okay? They take the edge off. They're not going to put you to sleep, and it's not going to take all the pain away, but it's going to help tremendously. It works fairly quickly within 10-15 minutes. It's going to last a couple of hours. And it's different for everyone. Each of you will metabolize drugs a little bit differently. This girl might be helped for 2 hours, and somebody else might get 4 hours of relief with it. And you'll knock off in between contractions. So when you have a contraction, you'll wake up. You'll know that you're having a contraction. It's not going to be nearly as sharp or as uncomfortable as it was before, but you'll know that you're having a contraction. Yes?
Will it affect the baby?
Yes. Does it cross over to the baby? Absolutely. Is it going to cause any problems? Very rarely, and we'll talk about that.
So why don't people just go with epidural right away?
Well, because it's not for everybody, and wait until you see the whole package and then you'll understand why. It's not for everybody. Some people want an epidural right away, as soon as they come in the door, okay? Or they want to go straight to an epidural and not to a narcotic, and I have no problem with that. But this is about choices, right? So choice number one, you have a narcotic. We give you another injection as we need it. So if you're 5-6 centimeters dilated, we give you another injection. It's going to work again for a couple of hours. But remember that as you get farther into labor, you go a little bit faster, because this is what the curve looks like. So it might take, 2 hours to go from 3 centimeters to 4 centimeters, but it's going to take 20 minutes to go from 8 to 9. All right? So it progresses much more rapidly as you get farther and farther along the curve. The reason it's a concern is because the morphine makes you a little bit sleepy. And I don't want you sleepy at the time of delivery. So here you are, you're 5-6 centimeters dilated. Will we give you another injection? Sure. And probably by the time it wears off, you'll be ready. You'll be 8-9 centimeters, you'll be fully dilated, you'll be ready to push. If you're 9 centimeters dilated, am I going to give you some more morphine? Not likely. Not likely, because you're going to be fully dilated, and we're going to want you to push. I'm going to come into the room and I'm going to say, okay, it's time to push, and you're going to say, who are you? What town is this? What are we doing? I'm being a little facetious. You're not going to be able to push as well if you're drugged. And on top of that, it does cross over to the baby. And we don't want a sleepy baby. So are there issues? Sometimes there are. And sometimes we make a mistake. We give you an injection. You're 6 centimeters dilated, and an hour later, you're fully dilated. Okay? And maybe you'll be able to push, maybe you won't be able to push, and sometimes you push well, and we deliver a baby, and the baby's a little sleepy. Okay? So does that happen? Absolutely. Can we reverse the effect of the morphine? Yeah, we give the baby an injection of another drug to try and reverse the effect. It's never a good idea to give one drug and then give another drug to reverse the effect, but do we have to from time to time? Sure. Okay? But we try not to get into those situations, but sometimes they're completely and totally unavoidable, especially in a girl who's had a baby before, and the second part of the labor is going to be much faster. Okay? So morphine works. For that girl who still doesn't want an epidural, and she's getting close now, she's 9 centimeters, she's almost ready, we can give you some nitrous, we can give you some gas to breathe, okay? Some nitrous oxide. Now, we're not going to give you nitrous when you come in the door. You're going to be labor for 12 hours. We're not going to be having you breathe through a mask. You're having a baby. You are not going into space. So we're not going to give you this nitrous to breathe for 12 hours. But is it useful? Yes. But it's an anesthetic gas. Okay? So it will put you to sleep. So here's the deal. If you're going to use this mask, and we use it from time to time, you have to hold it. Your husband is not allowed to hold it, because he's not an anesthetist, and you will fall asleep. So you're breathing the gas, contraction's gone, take it off, or you'll fall asleep or get sleepy and it'll come off your face and you'll breathe room air, okay? I don't want to see you take the mask and put a pillow over your head or take a roll of tape and tape it on, okay? No doing that, okay? That's not how we're supposed to use the nitrous, and there's probably going to be a nurse in there with you, so you're not going to get away with that. So does the nitrous help? Yes. Does it help for a long time? It's not practical. It's not practical, okay? Now again, you're fully dilated and you're pushing and you still don't want anything. But you might need an episiotomy. An episiotomy is a cut where we make an incision in the perineum to make room for the baby to come out, okay? And some people will say, I don't want you to cut me. Let it tear. Ay, 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 ay. We're going to talk about that. I don't want it to tear, okay? It's going to stretch and then it's going to tear and then I'm going to have a harder time sewing it up. I want to talk about episiotomies a little bit later on because it's an issue. But if we do an episiotomy, or if you have a tear and I have to sew it up, we're going to put in some local. Okay? So for that girl who still doesn't want anything, doesn't want an epidural, wants to go as natural as possible, but needs an episiotomy or something, we're going to put some local in. Okay? Cutting it is not the issue. If you're pushing and it's stretching and I cut it at that point, you won't even feel it. Sewing it up is another issue. So we're going to put some local in. I'm not going to try and sew it up with you moving all over the place and hurting you. That's not the game. All right? So a local anesthetic is also a possibility. Right? For some people, we use what's called a pudendal block, where we block the nerves uncommonly. Okay? We still use it once in a while, but not very often. So it's still a possibility for pain relief. But the most common thing that we use for girls who are having a first baby, or a second or a third for that matter, although less frequently for them, is an epidural. And everybody's heard about an epidural. So I want to spend a little bit of time talking to you about epidurals. Should I have one? Shouldn't I have one? Are there issues? Okay? So here's the story with an epidural. When can I have one? You can have an epidural whenever you need it. Now, that doesn't mean as you walk through the door. When should you have an epidural? You should have the epidural when you're so uncomfortable that you say, I'm really not enjoying this at all. I need something for pain relief. And this is what I want. And the difference between an epidural and no epidural is the difference between night and day. Okay? I'm in pain. I'm not in pain. That's the difference. Okay? Huge. Not like with morphine. I have pain. I have less pain. I'm sleepy. I don't know what world I'm in. With an epidural, you know exactly where you are. Okay? Not going to change your brain at all. It's going to take your pain away from here down. So you need to talk about this a little bit as well. Okay? Because it might be for you. When can you have an epidural? You can have an epidural whenever you need it. And usually I suggest that you get one when you're in good labor and you're about 3, 4, 5 centimeters dilated. You've had your taste of labor. That's enough. Thank you very much. I know what it's like. Don't want it anymore. Okay? You're in good labor. You're making progress. Here's the time. Can you have it later? Can you change your mind? I'm not sure I want an epidural. Can I change my mind a little bit later on? Yes, you can. But understand, be reasonable, right? You're 9 centimeters dilated. The anesthetist might be tied up, and we're going to talk about that. You're fully dilated and you're pushing. We can see this much of the baby. Is there any point to it at that point? I don't think so. Make an episiotomy and you'll push the baby out, or even without one. So be reasonable about when you ask for it. If you're going to have an epidural, you should get some good effect from it. So here's the story with the epidural. The epidural is given by the anesthetist, okay? An anesthetic specialist. I don't do anesthetics. They don't deliver babies. I do my thing. They do their thing. So we call the anesthetist. If it's during the daytime, there are lots of anesthetists that are available. One is on call for the labor room. So we put in a call for the anesthetist. The anesthetist will come over. He'll talk to you and give you some information. Some of them are a little bit better than others, I'll tell you the truth. And you'll get an epidural, usually within 15 to 20 minutes. Nighttime, weekends, holidays, one anesthetist is on call. If the anesthetist is in the hospital and not doing anything, he'll be over in 5 minutes. If he's at home, they've got to call him in. So 20 to 30 minutes to call him in. If they're tied up in the operating room doing a case, and that happens, we have an issue. The anesthetist can't really be in two places at one time. If he's with a patient who's anesthetized and having an operation, he has an obligation to that patient. And I don't think that it's safe or fair for him to walk out of the room and deal with you, because you want the anesthetist to be focusing on you and concentrating on you, not thinking about the other person, oh my God, I got to get back to the operating room. You want it to be concentrating on you. So if they're doing a case, you're going to have to wait. So here's what happens. Very often, if they're going to do a case in the operating room, the anesthetist will walk over, if he's the one on call, it's now nighttime or weekend or holiday. He'll walk over from the operating room to the labor room, and he'll say, does anyone want an epidural? Because if you want one, I'll put it in now. Because I'm going into the operating room and we're going to be tied up for the next 2, 3, 4 hours. And over that period of time, if you want an epidural, you're not going to get one. Understand, fair is fair, and safety is always an issue. So make up your mind. If you want one, he'll put it in. If you don't want one, understand that for the next couple of hours, he's not going to be available. And I think that's reasonable. From time to time, the anesthetist will come by at 11 o'clock at night and say, you know, there's nothing going on in the operating room. I want to go home. I want to go home. And there's nothing keeping him in the hospital. And he'll say, if you'd like an epidural, I'll put it in now for you. Make up your mind. Because if he goes home and then he gets called back at 3 o'clock in the morning and it's you, he's not going to be amused. He's not going to yell at you. But, you know, right? It's 3 o'clock in the morning, and I think that you would rather